No problem.
Hello, everyone. It's nice to participate in the IVF Babble Virtual Fertility Expo, and this is a webinar that is organized by Redia IVF. My name is Dimitris Kavakas. I'm the CEO of the company, and we are the leading provider of refund guarantee programs in Europe. I have with me today Dr. Tomas Frgala, who is a specialist in the field of reproduction medicine with exhaustive experience of over 20 years. During his work at the University of Southern California in the US, he participated in numerous projects and studies focusing on research and new substances in tumorous disease treatment, if I'm correct, doctor. And recently he has engaged himself in research of new methods in the field of assisted reproduction. He's the head physician at Unica Brno clinic. As far as I know, Unica in Czech Republic has two clinics, one in Prague and in Brno. Tell us a little bit about your clinic, doctor.
The clinic in Brno has a long tradition. It was one of the first private IVF clinics in the Czech Republic. And it originated approximately 20 years ago. So it has a long tradition, a lot of experience, and we're very proud of our IVF program. About 5 years ago, we opened actually, or the management opened a sister clinic in Prague, which is practical for many patients coming from Europe, hitting the Prague airport, so it's closer for them. However, the clinics are comparable in the procedures. We have the same SOPs, standard operation procedures, and the same or comparable quality of care. In Brno, we take care of over 1,000 cycles or 1,000 couples per year, offering a wide range of treatment, starting with conservative treatment through IVF cycles, cryo-embryo transfer cycles or frozen embryo transfer cycles, and egg donation cycles. Eventually, we have a program where we can use both male and female donors if need be, if the diagnosis in the couple requires that. So Brno is actually easily reachable from Vienna. So for anybody coming from down south, that might be actually easier to reach. Anybody coming from up north, maybe Prague is the choice. Otherwise, as I said, both clinics and the results should be comparable.
Great. So it's as Redia is concerned, we are very happy to partner with Unica, offering our refund guarantee programs in Czech Republic with them. So starting in this discussion, doctor, for our audience today, who are couples that are actually now watching us live at the IVF virtual fair, but also this broadcast, this webinar will be available later on. So there are many couples who may be watching us later on. They are concerned about success in IVF. What would you say are the factors that influence a successful result in IVF?
That's a very good question and rather complex one. The quality of the cells, of the gametes, and the quality of the resulting embryo when the egg and the sperm cell are joined is probably the decisive factor. And according to literature, it carries about 80 or 90% of the responsibility. So the quality of the embryo itself is crucial. We have to look into the age of both partners, at their results, at their previous experience, pregnancies, surgeries, previous treatment. What can otherwise, so basically, it needs to be carefully, the treatment needs to be carefully individualized. We always need to talk with the couple and see what the starting point is. In the actual cycle, as I said, quality of the cells, quality of the embryo, these are very important, but we need to also pay close attention to the endometrial growth. We need to control the uterine lining and see if the height and the structure of the lining are fine. We check hormone levels and we substitute some hormones that are necessary, sometimes estrogens, pretty much always gestogens, so progesterone. So the quality of the endometrium is also very important. But we can't forget the general support for the couple, their well, being, the feeling, the psychology of the cycle, and of the whole treatment. These are very important too. And it's very hard to generalize because everyone needs something a little bit different. So it's important that we stay in touch, that we communicate, that we cooperate. We have a team of coordinators, and we try to give each couple a chance to communicate in their own native language, in their native tongue, be it English, German, French, Italian, Polish, Serbian. We have translators, for instance, for couples from Hungary, to try to give them the patients, or to give the couples actually the support they need and the feeling that they're being taken care of 24 hours every day. So all of these things play a role. And then knowing the case and knowing the situation, we can go into more detail. Genetics, hematology, immunology, or these other examinations and support systems are available eventually and will be employed if the situation requires that.
Okay, so, but when we talk about success, I know that there are different ways of measuring, but at the end of the day, couples want a baby. So we're talking about a live birth, but then clinics publish success rates, pregnancy test, heartbeat rate, 12-week gestation. What is the difference, and how can a couple look at success rates and of what they are interested in?
Yeah, very good question. Usually the data that's presented, because that's the one that's easier or the easiest for the clinic to follow, is the biochemical pregnancy rates. So the rate of positive HCG tests, which confirms that the embryo has nested, the pregnancy has started, and the organism of the mother is reacting accordingly, and the HCG is rising. That does have a certain value, and it is important to start with this number, which is actually taken usually like 2 weeks after the embryo transfer, and that point represents week 5 of the pregnancy, being calculated from the date of the menstruation. Another 2 weeks later, around week 7 of the pregnancy, we should be able to actually see the pregnancy on ultrasound and see the heartbeat. And if we do confirm the heartbeat in the baby, then this is being called a clinical pregnancy. And of course, that has a higher value because some of the pregnancies, the biochemical pregnancies, they stop eventually, and the heartbeat cannot be diagnosed. Still, this being around week 7 or 8 in the pregnancy, we still have like 4 very sensitive weeks to go until the end of the first trimester. If the pregnancy successfully goes through these initial 12 weeks, then the chances are very high that it's going to be okay and that it's going to continue. Still, there could be complications during the pregnancy. Most of those, however, are not in connection actually with work at the clinic, not really in connection with the original quality of the embryo. These are problems that actually come de novo, that are new and fresh during the pregnancy itself. So ultimately, the take-home baby rate or live birth rate, of course, is the most interesting statistic. But this one is very hard to reach. I have to admit, even for us, this is rather complex because many patients are from abroad, and Many patients actually fail to give us the feedback that we need. We do know about the pregnancy tests, the biochemical pregnancy. That's easy because at that point they're still taking medication, and it's actually in their own best interest to stay in touch. After the ultrasound, and this is mostly performed in their country, wherever the couple lives. Most of them, once again, do give us the feedback. However, not all patients actually fill in the questionnaire later, 9 months later, perhaps, and let us know about the outcome of the pregnancy. We try to follow up on that, but not always successfully. So while the take-home baby rate might be the most interesting and the strongest statistic, this one is actually not always available. It's very hard to reach. So I would probably, as a compromise, focus on the clinical pregnancy. So whenever the pregnancy is actually confirmed by ultrasound, seeing a heartbeat in the baby, that's actually a very promising, a very strong point, even though I admit that some, and based on the source, some 8 through 12% of these pregnancies even can eventually stop during the first trimester.
Okay, so there is a 8 to 12% of miscarriage after the clinical pregnancy. What about before? What is the miscarriage percentage that you see from between biochemical pregnancy and clinical pregnancy?
I'm afraid I won't be able to give you that number exactly.
Just from your experience, average.
Yes, from my 12-year experience, that would be once again around 10%. Okay, once again 8 to 10%. However, what I'm trying to say here is that in some cases, the pregnancy actually might stop before the pregnancy test is even performed. So sometimes we see the HCG results of 8, 30, 40, and these are not clearly positive. Everything that's between, let's say, 0 and 5 is clearly negative, but 20 or 30 do give you a certain hope. But then the dynamic is important, and if the value goes down, we see that maybe there was an implantation for a couple of days, but the embryo stopped. So this goes actually hand in hand with what's written about a missed abortion, the early abortion, that most of them actually in the real world, in the natural cycles, they go undiagnosed because usually the woman doesn't even know that she was very briefly pregnant. So it's hard to give you an exact number, but actually looking at those positive tests and at those ultrasounds, my best estimate is somewhere between 8 to 10%.
Okay, so if you add this number, you're getting a good 15 to 20% of possible miscarriage. So you would agree with me that people who are into an IVF cycle, their ultimate goal is a live birth. So IVF doesn't work first time. So they need to know that they need to keep on trying. So they will be very lucky if they manage to have a baby from the first embryo transfer they ever done.
That is true, yes. Even if we do everything right, we still need a hefty dose of luck and cooperation from the nature. So you're right, not every cycle is successful the first time around, even though the success rates that we see in the past 5 years, past 10 years, they are quite promising and they keep going up. Whereas like 10 years ago, we still transferred 2 embryos per transfer on a regular basis just to increase the chance of the embryo implantation, because the success rates were somewhere around 25, 30, 35%. Nowadays, of course, we need to then specify, it depends on the patient's age and other factors, but it's not rare to see success rates in the own stimulation cycles around 50%, over 50%, even around 60%. In egg donation cycles, this might be even a little higher, and we're talking about the first transfer of one embryo. So more than half of the cycles are actually successful the first time around, but not all of them. And there is, and when I have to admit, when I talk about these success rates, I am talking about biochemical pregnancies. So not all of these will result into a successful birth. And there are couples where we need to try a second or even the third time. That is correct.
Okay. So my conclusion out of this is that it does make sense for couples to consider a refund guarantee multi-cycle program that will give them the insurance of whatever happens. They will eventually continue to do another cycle and another transfer, or get the money back in the event that they are so unlucky that they don't make it into a live birth after 3 full stimulation cycles.
That is correct. Yes, I have to agree. Admittedly, and I'll be quite open and honest with you, when I first heard about those programs, I thought, my first reaction automatically was, oh my God, how can you guarantee anything like that? Because there's so many factors. There's so many things that play a role during the pregnancy. Guaranteeing something like that, you're not only guaranteeing perfect work at the IVF clinic throughout the IVF cycle, but pretty much the work of the gynecologist that takes care of the patient afterwards throughout the pregnancy, the obstetrician that participates in the birth, actually the lifestyle of the patient herself. But still, eventually it started to grow on me, and I understood that psychologically for the couple this can be very reassuring, very important. It's always a lot of money. The methodology is very advanced, is very complex, and very expensive. So each of these treatment cycles, they cost a lot of money. And if there's anything like this, where there's eventually the guarantee that if for any reason it's not successful, and at least we always do our best to actually reach the ultimate goal, and that's the healthy baby. But if the couple or the patient can live at least knowing that if that fails, they'll get the money back, then psychologically this might be very important. Yes.
Yeah, that's actually correct. And maybe in English, the word guarantee, it can be misleading because you cannot guarantee the baby. Only God can guarantee the baby, not us. However, what we actually saying by guarantee is we insure. So it's insurance that they either reach their goal or they'll get the money back. So that is what is underlying by the word guarantee. But since you mentioned about psychology, and I reckon that psychology does play a role in success. Is that correct? Many women are stressed out and even blame themselves for failed cycles. Do you think that getting psychological counseling or getting themselves stressed less by a guarantee program or whatever way that each one choose to feel psychologically better, to be to have most psychological strength to get into IVF? Do you think that's a factor that influences success in IVF?
Definitely, and ultimately, I actually thinking about it, I realized that this was the crucial point of the whole endeavor, of the whole situation. There always needs to be communication, there needs to be trust to the doctor, to the coordinator, to the team, to the treatment itself. But still, the psychological aspects, they're undeniable, they're very important. Mm-hmm. But at the same token, they're very hard to actually to address, to identify, to quantify, pretty much impossible. This is different with every patient. This is different with every cycle, even in the same patient. So it depends on the surroundings, everything what's going on in the family, and ending up with the weather or the situation at work. So all of these factors play a role. Life's not easy. Life is always stressful. The fact that the couple came to us and needs treatment and attention, that in itself actually guarantees a certain levels of stress. And we are very much, aware of the studies that say that the most stressful specialization actually in medicine is oncology, no doubt. But number two, a close second place is IVF, actually, reproductive medicine. And knowing that, we try to set everything up, the treatment, the care, in such a way that the patient would be comfortable. But still, we cannot take care of everything. The psychological aspects are very important. Other studies have shown, for instance, that just by opening a 24-hour telephone line, a hotline for the patients, being always there, they addressed this group as the group with the quote-unquote tender loving care. And in the study, they clearly showed that patients in this group with more access, with more support, they got better, significantly better results. So that's a definite yes on the question about psychology. And ultimately, I realized that this program actually can play an important role, because the factor actually of the money of what this is costing the family or the couple, okay, this is very important. And knowing that, well, if it fails, at least we get the money back. This might be actually very soothing. It's going to have a different effect on everybody, but generally, this is definitely a positive. And I can only imagine what stress it is for the woman, for instance, going through that treatment, going through all the medications and everything, feeling responsible that, does the embryo nest? Does it not? Why? Why didn't it like my uterus? Why didn't it like me? And oh my God, it cost now the family this sum of money. So at least knowing that there is an insurance like that, it can make it a lot easier. And also it kind of tells you, it sort of guarantees. I know I'm using that word quite freely now, but it gives you an assurance that the clinic itself is going to really, really do their best. Okay, we're human, we're not gods, we cannot always win, but we will really do our best because it's in our own interest.
Yeah, that's correct. And also, apart from knowing that they will get the money back in case they are not the lucky ones to succeed, which only a small number of patients reach that stage. But they also have another benefit, which is they know from the beginning how much it will cost, because IVF is financially unpredictable. They go from cycle to cycle and they don't know how much they will cost them. So they know that at least this is the fixed amount of money they need to budget. They look for funding, they look for finance, they get the money, and they know this is all they're going to pay. So that's also an advantage. Going further in our discussion, and we talked about the female factors. What about the male factor? There's a lot of focus given to the equality, to the woman in IVF, but sometimes I feel, maybe I'm mistaken, you can tell me if you're experienced, that the semen quality is overlooked. How much success or failure can be attributed to men?
Just shooting from the hip, I say it's 50-50. They're both the gametes, both the cells are equally important. And it depends on the practice of the clinic. And this starts actually with the first consult and with the focus on the initial factors. But the spermiogram analysis always has to be there. It's one of the first examinations that we require. So we cannot overlook this, but sometimes it is overlooked. You're right, and we need to keep reminding ourselves that's an important part of the whole equation, and it's the importance is 50-50. We actually get more chances with the sperm cells. We can analyze the concentration, the motility, the morphology, their build. We can examine the DNA fragmentation percentage. We can even during the IVF cycle employ various selection techniques or selection procedures. That's not the case with the eggs. With the eggs, it's very difficult to assess their true quality. So we should be taking advantage of that. But I believe that you know, any IVF specialist worth their money knows that, and we don't forget. We sometimes during the treatment focus more than on the eggs, but we have to look at the spermiogram at the beginning. We need to check it every half year or so, and then in every cycle it's checked again. So that it plays a very important role as well. We cannot forget the gentleman. It's a 50-50 situation.
Good. And when you, given that a couple goes to a cycle and it fails, unfortunately, and this happens, as you say, it may be 50%, it may be 60%, it may be 40%, but there is a significant amount of couples that face this bad experience of failed IVF. What are the indicators that you look at to make a difference? Do you follow a different protocol at the next time? Or it's just luck?
Oh no, it's not just luck, even though luck is a part of the process. And admittedly, this is the million-dollar question. If you were able to go back and diagnose, pinpoint actually the moment where it went wrong, oh, that would be very easy. It'd be very famous and quite rich. It's not that simple, it's very complex, but there are things that we look at. And it's important, just as the actually introductory consultation with the couple is important, it's important to look back afterwards and then communicate via the coordinator or directly with the couple what our thoughts are, what have we learned in the cycle, because the treatment itself, the stimulation, the reaction of the ovaries, the fertilization rate, the embryo development, the in vitro cultivation of the embryos, these are all very new, very exciting, very important parameters for us, while planning may be the next step. So we need to take a look back, and we start, of course, with the age of both partners. We take a look at the initial quality of the gametes, in the gentleman, the spermiogram, in the woman, the AMH and AFC, anti-Mullerian hormone, and antral follicle count as the parameters of the ovarian reserve. Then we look at the stimulation, see how the ovaries reacted to the stimulation dose that we picked. We are mainly talking here about the cycles with the stimulation of the own ovaries of the patient. Was the number of follicles that reacted as expected? Was the dynamic of the growth as expected? If not, what can we do next time to adjust that? Do we use another protocol? Do we use a different dose of the medications? Then we look at the quality of the spermiogram on the day of the egg fertilization. We look at the fertilization rate, how many follicles resulted in an egg, how many eggs were ripe, and how many ripe eggs were actually fertilized. These are all interesting factors. Then maybe we have learned something from the 5-day embryo development, using the time-lapse technique, or even the classical, I mean, the standard technique, checking them once a day. We look at the dynamic of the growth, and we look at the quality of the gametes on day 5. We look at the test result itself, and we look at and this is very important, at the number of embryos that actually were there following the 5-day cultivation. That should give us quite a strong actually idea whether the cycle is promising or not. If you start with 10 embryos, which result in 5 blastocysts, you can think, even after the first, lack of success, after the first unsuccessful transfer, no worries, it's going to be okay. Maybe we'll check the hematology, we'll focus on the endometrium, we'll double check the hormones, but we have other 4, 5 beautiful blastocysts, we still have a very strong chance. It's different when we start with 10 embryos and on day 5, there's just 1. Then we suspect something might be wrong here. So once again, we need to individualize. And if this is the case, then maybe we do blood tests in both patients and run a genetic consult just to see if there's maybe a hidden aspect, maybe a hidden problem in the karyotype. One of the patients might be a healthy carrier of some kind of mutation. So we can look into these. We can look at the hematology, the blood clotting issues, eventually at the immunology. There it gets quite complex. We can eventually, if we don't like the endometrium, if there's anything suspicious on the ultrasound, we can think about the hysteroscopy. Then we put all of these results together and then we continue. I'm not saying that all of these examinations are necessary after every failed transfer, but I'm just naming pretty much, the whole scale of methods that we eventually have available. Mm-hmm. And we have to pick based on the situation of the couple, based on the number of embryos and the whole history.
That's very good. That's excellent. The other question I would like to ask you to discuss is the egg donation treatment. We know that Czech Republic is known as a destination for egg donation. Does it really matter where someone goes for donation treatments? To my experience, I have 5 years working with Redia and providing refund guarantee programs. There is a difference from country to country on the quality of donors they have. In some countries, they have donors that provides eggs that are not that good quality than others. I don't know if that's just a perception that I have from working in different areas, or it's actually a reality that takes place. And also, I would like to ask about the success rates that different clinics advertise. Patients go around clinics for egg donation and they say, oh, we have 90%, we have 95%, we have 100%, everybody succeeds. Is that misleading information? It sounds like it, but I would like your opinion.
Wow, that's a very tough question. Well, I'm going to start at the end when you say that there's differences and sometimes 100% success rate presented. In that case, we do need to dig deeper, okay? We just said that there's many factors playing a role, and just saying 100% success rate, that's quite simplified and it sounds very optimistic. So what does it really mean? Is it after one transfer, or is it the cumulative success rate? And if so, is it the cumulative success rate in one cycle where maybe you have 3 or 4 embryos resulting in 3 or 4 transfers? Or is it 3 cycles in which in each of them you have 3 embryos? So we're talking about a total of maybe 10 transfers. And then we're getting close to 100%. Honestly, whenever there's biology, nature, the higher power in question, in play, I never dare to say 100% because, things can happen. And that to me, that sounds very, very optimistic. But the cumulative success rates, even here, at least regarding the biochemical pregnancies, are close to that actually. 3 cycles, multiple transfers in each. The success rates, the cumulative ones are 97, 98%. So this is not an exception. But if you compare the clinics, if you compare just the numbers, you would have to dig deeper. You would have to ask. I know it's not easy. I know sometimes the patients ask around, and they go through consults at various places, various clinics, and then eventually they learn something from that consult and from the approach, the communication level, and maybe then make their choice. Also, if it doesn't work the second time around, sometimes they change the clinic, and just the change of place, sometimes the change of rhythm, change of the details can sometimes help. But generally, just knowing the competition, and here, wow, I might be talking, and just be against myself if I say that, but it should be fairly comparable. Everybody's proud to make their job, okay, to the best possible way, and to be able to take good care, feel good about it, and eventually brag about it, okay, present the data and say, look how well we're doing. So I think that we need to, of course, trust and rely on the professional pride as well. But otherwise, there might be differences in the approach, in the communication that plays a role in the psychology of the whole process. And as I said, the devil's in the details often. So maybe those might help. And I'm not going to go as far to say, just come to us, we're the best. I know that many other clinics are very good as well. That it should be pretty much comparable. But still, the patients, they need to sort of come and see for themselves. And it's a question of communication, experience, and trust. Regarding the initial part of the question, I mean, the ethnicity or the racial differences, I have to admit, you caught me off guard there. You have more experience than I do. I don't really have much a chance to compare success rates or data from various places, various countries in Europe. I'm not going to name them because I don't want to be too specific. And this is not just trying to be diplomatic. This is simply because I'm not familiar in detail with all the legislatures, because it's not available in every country, the egg donation. So it's the question of the legislature, of the options, of the possibilities.
My question was more like, for example, the extent of the age of the donor. We know that it's important to be young. However, what is the importance of the background of the donor? The background in where the society lives, the food she's eating, the activities and the hygiene in which she grows up. Is that important for the quality of the eggs? That was my real question. I was not going to compare, because Redia is working with many different countries, so and many different clinics. So we're not going to compete. The question really was whether the background in which the donor it grows up influences the quality of her eggs and her fertility.
This is actually, oh my God, this is a very interesting question. And I heard of a very interesting talk that actually goes in that direction. This was from the United States, and it showed that the success rates can be significantly different when you compare different areas. It wasn't just states, but it was the parts of the state. And depending on the welfare, on the well-being of the area, actually, you could estimate the success that the IVF treatment is going to have And it was, of course, the success rates were much or significantly lower in the poor areas, starting with, worse or poorer nourishment and the more problematic lifestyle. Maybe I'm not blaming the patients here. Maybe my English is not quite flexible, at this point. But the lifestyle, the possibilities, the comfort of life, yes, all of these do play a role. And I cannot possibly say, nah, that's not that important. It does play a role. But within, if the whole country or the whole state or the whole region is on a certain level, then it's more of a question of the screening process, of the admission process. And I know that these guidelines actually, which all the clinics they have to follow, are similar all over Europe, okay, in testing the donors. Still, there might be some small differences. And actually, the patients might be interested to hear that in the Czech Republic, since about 3 years ago, there have been some extra tests, actually, genetic tests implemented, because we have a quite agile, active society for medical genetics and genomics that came up with some suggestions that eventually from the Czech Ministry of Health were accepted and set as the new standard. So there's some more tests actually that are not provided in other places or in other countries, but still the screening process is important. For instance, in the legislature, the age in the donors should be between 18 and 35. So anything within that range is fine. It's legal. Still, we try to take rather donors for between 20 and 29, just for ethical reasons, trying not to stimulate 18, 19-year-old girls, but to mainly not taking women over 30, because there are many statistics that show that after 33, the quality of the eggs might be slowly, deteriorating, might be slowly dropping. So while 35 generally is still concerned as a reasonable cutoff, okay, and it still guarantees a good quality of the oocytes. The quality of them should be best between, let's say, 18 and 29, 18 and 30. So that's the group that we try to focus on. But still, you need to focus on the lifestyle. You need to organize the questionnaire properly so it would reveal enough about the candidate. You need to talk to the candidate in person. So they go through not only like a health interview, but a psychological review, and then a very detailed genetic consult with a geneticist, with a specialist, including all the necessary blood tests. So the screening process or the inclusion process is very important, and the rules are actually quite strict here in the Czech Republic. So maybe that plays a certain role.
Okay, great. That's very interesting. My next question or topic to the expert doctor will be, what is the contribution of expensive equipment in IVF? We know that the IVF laboratory is one of the most important elements in IVF for success, but is that so important, or is also a part of the marketing campaigns? Because things like time-lapse, which is very expensive, not all the clinics can afford to buy a time-lapse. Does this play a significant role in success, or other techniques that the lab uses, like embryo glue, assisted hatching? Is that marketing tools, or they are really important in changing success rates?
This is a very tough question, and you know that I just can't possibly tell you, yes, we have these techniques, we employ and recommend these techniques, but nah, they're not really that important.
How important they are? Are they for everybody? I mean, you may apply assisted
That's
hatching, but
that's
is
a
it for
very
everybody?
important.
Yeah, yeah.
Very good. Okay, so let me split that in three questions. Okay, the importance of the lab and the equipment, the importance of the time-lapse technique, and actually, are they for everybody? Okay, so the lab is crucial. It's the heart of the IVF treatment or of the IVF clinic. So the equipment, but also the personnel, the experience, the know-how, these are very important, okay? And as they evolve, the success rates go up as well. So this is quite crucial. The lab and the quality of the personnel, the equipment is quite crucial. On the other hand, I'm not saying that every new machine, every new procedure, every new toy, pardon the pun, that is available is going to be very important from the get-go. We need to have it tested before we even implement it. We need to think hard if we really need it, and if it's going to help us, if it's going to help the patients, if it's going to help us helping the patients, so to speak. And this is always a very tough discussion. We actually with every development, but usually no clinic is basing their decision whether to purchase that equipment, okay, basing it on just one study or one experience. So most of the equipment that we do employ is actually well tested and well needed also. Some of these methods grow kind of old and they fade, like the sperm selection via IMSI. It hasn't been recommended and used for years now. Or the PGS, the pre-implantation genetic screening using the FISH method on day 3, the fluorescence imaging, not used anymore. These have been replaced by much stronger, much better methods. It's not easy. It's pretty much impossible for the patients to orient themselves. It's tough sometimes for us, the physicians, to actually keep up with the embryologists, but we have to do our best and we have to inform the patients eventually so that we can answer questions like this. So you have all the necessary equipment. Yes, you can perform the sperm selection methods like PIXI, MAX, or the microfertile sperm selection chip, okay, available. You can do the genetic testing, the PGT-A, the PGT-M. Yes, we can do that as well. You can do the time-lapse technique. Yes, we have that too, because if you don't, many clinics, the majority of clinics have that now, then the patients feel like it's something amiss, okay? Oh, how come? You don't even have that yet. And it's not easy to step in the middle of that crossfire, of that discussion of how important it really is, and try to be the judge saying, oh, it's not that important. Oh no, this is really, really crucial, because with some of these methods, the discussion is still open. The jury is still out. It's still going on. We're still collecting new data, new studies. Sometimes there are dozens, hundreds of studies before we can do the meta-analyses and say conclusively, what is the situation here? So coming to the second part of the question, for the time-lapse technique, for instance, there's still those roundtable discussions at the big meetings at the congresses, okay, titled something like time-lapse technique, the true future of embryo selection, or just a luxurious cultivation box. And there's somebody who speaks, you know, for and somebody against, and usually it's a close draw in that discussion. So you have to look at these and you have to take what's important for you. You have to make the best out of that situation. To that I say, And then coming to the third part of the question, okay? If it's reasonably priced, and I'm very proud, for instance, of our management that actually includes it in the package, and as a part of that package, it doesn't cost much, the time lapse. So it's becoming more of a standard, and I like to see that, because even if it's just a luxurious cultivation box, hey, that's a plus. It's good for the embryo. It deserves a comfortable, okay, stress-free cultivation. So even that aspect is interesting for me.
Mm-hmm.
But yes, the question is, okay, of course, is it worth the price? So if the price is reasonable, even that is, but there are many studies that show now that it actually is of advantage. And while it's not perhaps 100%, it's not set in stone. I'm not going to be the judge here. I'm not going to, you know, try to look at where dozens of my colleagues are still kind of discussing this and struggling with this. I'm going to step in and say, no, I know. I'm going to decide now. No, I'm not that proud. But I feel, for instance, with this technique, that it does bring it certain advantages. The embryologists say so, and they use it, and they show me what it does and how they can use it. The parameters are still not quite clear. Yes, the studies are still going on, but I do believe that it has a set place in the embryology lab and in the whole procedure. Other methods like embryo glue, assisted hatching, it's difficult. You're really grilling me here, okay, opening these discussions.
That's okay. That's okay. We
These
briefly.
have been used for years. Yes, we use them as well. And it's pretty much a similar answer. I heard a very interesting talk by Professor Everett. I hope I'm saying the name correctly. In Sevilla last year. Oh, it's been just a year ago, and coincidentally, there was the last Congress where that I was able to attend live. You know, from that point on, it was all online, thanks to the COVID pandemic. But that was the last Congress where I was present live, and he had a very interesting talk about endometrial scratching and about how it looked really promising, but ultimately the latest studies, the strong, the robust, the randomized studies failed to confirm its effect. Still, in the following meetings, online meetings, the colleagues were still kind of arguing about that and fighting about that. And he was talking about the other methods as well. And he actually cautioned us to be, you know, quite careful here, that pretty much none of these are like 100% confirmed. So more studies, more experience, more data will give us a better chance to answer that question perfectly.
Okay.
But we don't use anything that's not helpful. There's no room for clutter in the embryology. This is a very sophisticated process. Sorry.
Perfect. Dr. Frgala, thank you very much. We are coming to the end of this webinar. I just wanted to close by saying that it looks from our discussion that a patient would need an average of 3 stimulation cycles to make sure that they reach the 90 and 95% success, or at least have a good chance to have their baby home. So a refund guarantee program is designed with that in mind. So to give the peace of mind and the financial stability to the patient, so they can get what they want, which is the ultimate goal in IVF. So by saying this, I would like to hear your concluding remarks.
I will dare to not correct that, but to follow up on that. An average of 2, maybe 3 cycles, treatment cycles, yes, but we have to specify that this is not stimulation cycles, but treatment cycles. Because in some patients, we try once, the ovaries don't react. There's 2 eggs and only one of them ripe and no success. maybe we can try a second time, but you know, if it's even worse, it doesn't make sense to stimulate the own ovaries of a patient a third, fourth, fifth time. That's one example. Another example, patient comes 45 years of age with a very favorable AMH and actually a favorable number of follicles. Everything was great. Still, we know that the quality of the eggs is going to be problematic, that the success rates around 45 are lower than 1%. It's practically zero. And that it doesn't really make sense to stimulate the ovaries. So we're not going to stimulate these ovaries 3 times trying to achieve success. We need to stay open to discussion and to the recommendation and eventually to the possibility of donated gametes, be it the donated sperm cells or eggs. So this is important. This is an important detail, but generally, yeah, I agree with that estimation that 2 to 3 cycles should suffice to reach a very high cumulative rate. Once again, talking about 3 stimulation or treatment cycles with perhaps multiple embryos and multiple transfers. So I think that that is true. We still always need to stay humble. We need to try meet the nature halfway, and then, you know, ask for a little assistance and a little luck. But in doing so, we have a good chance, and we'll do our best to succeed each and every time. We always do.
Great. And at this point, I would like to thank all the audience who followed this webinar, either live now or later on in IVF Babble TV. And also, I would like to thank IVF Babble for this opportunity to have us and host us in this virtual fertility expo, which is the 3rd in a row they do this year, and more are coming. And most of all, as on behalf of Redia, I would like to thank our partner clinic Unica and Dr. Frgala for his time and his expertise. Thank you very much, Doctor.
Thank you for the opportunity and for the fun talk. It was a pleasure, and I'll be looking forward to talk to you or the patients in the future. It's fun.
Thank you. Thank you.
Thank you very much. Good luck. Good luck to you all.
Thank you.